The probability of persisting doubling of plasma creatinine was significantly higher in patients who had renal flares compared to patients without renal flares. Of note, there was a difference between proteinuric flares and nephritic flares. Proteinuric flares, when treated, of course, had an excellent prognosis in the long term, while many patients with nephritic flares had a doubling of serum creatinine. Another parameter that has been particularly emphasized by the group of the NIH is anemia at presentation. And also in our experience, patients with anemia had a worse outcome in the long term than patients without anemia. And the same was true for the positivity of antiphospholipid antibodies. An underrated factor that can influence the prognosis is the poor adherence to prescription, which is actually a major cause of flares and progression to renal failure. And there is agreement that the more complex is the treatment, the lower is the adherence to prescriptions. And some subjects are particularly prone to poor compliance, namely adolescents, patients with aesthetic disfiguration, those with poor socioeconomic conditions, those with social isolations. And we should try to improve our communication with our patients and to try to render the treatment less complicated as possible. But certainly the most important prognostic factor is treatment of lupus nephritis. And generally speaking, today treatment can be subdivided into induction therapy aimed to treat active phases of lupus, including flares, and maintenance therapy aimed to try to maintain stable renal function, while trying also to reduce the side effects of treatment. And induction therapy usually consists of 3 high-dose intravenous methylprednisolone pulses, followed by high-dose oral prednisone for 8 weeks or so, and then prednisone is usually tapered. But in most cases, this treatment is also associated with cyclophosphamide, either given intravenously or by mouth, or mycophenolate salts. Maintenance therapy mainly rests on the lowest and best tolerated doses of corticosteroids associated with azathioprine or mycophenolate salts. Recently, Anderson and co-workers made a meta-analysis of randomized controlled trials that compared mycophenolate mofetil with intravenous cyclophosphamide for induction therapy. And they couldn't find any significant difference in mortality, incidence of end-stage renal disease, complete renal remission, and renal relapse. However, patients given MMF had significantly lower risks of ovarian failure and alopecia. They also made a meta-analysis of randomized controlled trials that compared azathioprine with MMF for maintenance therapy, and they showed that the risk of renal relapse was significantly higher with azathioprine. Today, the prognosis of lupus nephritis is considerably improved. Nonetheless, a number of patients still enter end-stage renal disease. And these patients can cause a number of problems for the clinician. The first of them is whether renal failure is actually irreversible. By reviewing the literature, it appeared that about 10 to 28% of patients with lupus who needed dialysis had at least a partial recovery of renal function. However, identify those patients who can have a partially reversible renal failure is not easy at all. The rapid course of the disease more frequently is associated with potentially reversible lesions. Ultrasonography can certainly help, since shrunken kidneys or kidneys with poor corticomedullary differentiation or strong hyperechogenicity have low chances of having a recovery. And renal biopsy can also be important in difficult cases. But again, there is another important problem. What should we do with treatment? Because given an aggressive treatment to anuremic patients can expose him or her to severe and even life-threatening complications. On the other hand, to reduce immunosuppression can preclude a potential recovery. And certainly the age of the patients, the clinical conditions, the previous immunosuppressive treatments can help in taking a decision. However, the expertise of the clinician and the good sense of the clinicians are irrepressible in this setting. The other point is what is the life expectancy for lupus patients on dialysis? Generally speaking, the impression is that the prognosis of lupus patients treated with dialysis largely depends on the severity of pre-dialysis comorbidity, especially infection and cardiovascular disease. And patients who received a high-dose steroids or immunosuppressive therapy at the beginning of dialysis are more susceptible to infection and have a poorer survival than patients who enter dialysis with a quiescent disease and low-dose steroid therapy. By reviewing the literature, Dr. Stones, a few years ago, reported that the survival of lupus patients on dialysis was comparable to that of non-lupus patients. And the more recent report of the day1 National Registry also reported no difference in 8-year survival between dialysis patients with lupus and patients without lupus after adjusting for age, sex, dialysis modalities, and comorbidities. In the early period of dialysis, the first 3 months particularly, the most frequent cause of death is sepsis due to the heavy immunosuppression used in patients with hectic activity. In the long term, cardiovascular and cerebrovascular complications are the most frequent cause of death. However, the risk of cardiac infarct or cerebrovascular disease after adjusting for confounding factors was similar in lupus patients and in non-lupus patients excluding diabetes in this review of the USRDS data. Another important issue is lupus activity in patients on chronic dialysis. By reviewing the literature, I found that between 7 and 67% of patients on dialysis had at least one flare of lupus activity, with a rough mean of 33%. Thus, many patients on regular dialysis show subdued biological and clinical activity, but about 1/3 of them can show an active disease. Activity is more frequent and severe in Black patients, and flares are particularly frequent in the first year. However, we have an important point, which is the differential diagnosis between infection and flare-up in a dialysis patient. Actually, we don't have good parameters for this differential diagnosis. Erythrocyte sedimentation rate is increased in both instances. C-reactive protein is increased in infection, but is often increased also in lupus flares, particularly when they are associated with serositis or arthritis. Blood cultures are always positive in infection, or better, whenever positive, they testify an infection, and they should be negative during flare-ups. However, let me remind you that in many cases, flare-up can also be complicated by an infection, and in these cases, the treatment is particularly difficult. It is well known that serum complement can be activated during an infection, and it can be usually low during flare-ups, and the same more or less is true for anti-DNA antibodies. Therefore, the differential diagnosis between flare and infection is difficult, and even more important, either of them may trigger the other one. Treatment of flares in dialysis patients is also particularly difficult because it can be responsible of a life-threatening adverse event. And many investigators suggest to use in dialysis patients the same treatment used in patients with preserved renal function. My feeling is that it is safer and probably equally effective to halve the doses of intravenous methylprednisolone pulses and of immunosuppressive drugs. And let me point out that flares occur rarely in the long term, but nonetheless patients should be monitored regularly to prevent lupus-related complications. And this may be also demonstrated by this study made on patients treated in a tertiary care center. And the investigators reported that the risk of death was significantly higher in patients who were seen less than 2 times a year by the specialist than compared to patients who were seen more frequently by specialists. Just a consideration, I hope that your patients are visited more frequently by a nephrologist. At least in Italy, we see our patients every week or at least every 2 weeks. But apart from flares, should lupus patients on regular dialysis receive continuous immunosuppression? Again, in this study of Brother and co-workers on tertiary care patients, they pointed out that the patient mortality was higher in those patients who didn't receive any treatment or received only prednisone. Instead, patients who received prednisone plus hydroxychloroquine or plus immunosuppressive drugs had a better probability of survival. Again, I don't agree with these conclusions because in a retrospective studies made in Italy on lupus patients on dialysis, it was shown that giving steroids for more than 3 months resulted in less favorable nutritional conditions, lower serum albumin, lower body mass index, and more infection than occurred in non-steroid treated patients. And in this paper from Stuart Cameron in the UK, patients on peritoneal dialysis who received steroids or immunosuppressive drugs had more peritonitis, more hospital admission, more laparotomies to remove infected catheter, and more infection due to Staphylococcus aureus or fungal infections. And it is easy to understand why persistent steroid or immunosuppressive therapy can favor infection in dialysis patients. Because, as you know, in the uremic milieu, both innate immunity and adaptive immunity are defective. Dialysis patients may have comorbidities, including diabetes, older age. They can be carrier of Staphylococcus aureus in their nose. They can be malnourished. The dialysis success, particularly arteriovenous fistula and intravenous catheter, can favor bloodstream infection. And moreover, the contamination of dialysis equipment may also favor infection. Therefore, patients should be visited by a nephrology expert in lupus at least once every month Flares should be treated as soon as possible, but the doses should be adjusted to the clinical conditions of the patient. In subjects without evidence of clinical activity, the maintenance immunosuppressive treatment should be maintained in the first few weeks and then gradually tapered and completely stopped after 6 months or even earlier if no flares occurs. The other point is hemodialysis or peritoneal dialysis. This morning, it has been pointed out that peritoneal dialysis can preserve renal function, and this is an important advantage. However, patients who receive high-dose steroids at the beginning of peritoneal dialysis may be more susceptible to infection and can have a poorer survival technique when compared to age and gender-matched patients without lupus. Serositis may predispose to sclerosing-encapsulated peritonitis, and extrarenal lupus complications can occur after peritonitis. On the other hand, hemodialysis not only can reduce early renal function and diuresis, but can also favor the production of antiphospholipid antibodies, particularly when a patient is treated with the cuprofen membrane. And lupus patients carrier of antiphospholipid antibodies or lupus anticoagulant have an increased risk of thrombosis or stenosis, of vascular access for hemodialysis, but also have an increased risk for deep venous thrombosis. In this comparison between hemodialysis and peritoneal dialysis, there were no significant differences in the main demographic characteristics. The risk of death, of infection, and of cardiovascular disease were similar between hemodialysis and peritoneal dialysis patients, but the risk of lupus flares was significantly higher in hemodialysis-treated patients. On the other hand, the technique survival was significantly lower in patients treated with peritoneal dialysis in comparison with hemodialysis. In this national registry made in Taiwan this year, it was shown that male lupus patients treated with peritoneal dialysis had a significantly better outcome than males treated with hemodialysis, while there was no difference for female lupus patients between the two different dialysis modality. For lupus patients on hemodialysis, male sex, age, high or absence of daily steroid dosing were predictive of higher mortality. For patients on peritoneal dialysis, age and high daily steroid dosing were predictive factors. The last issue is dialysis or transplantation. Bonapratis and co-workers reviewed the EONOS registry, and for patients who received a kidney from a deceased donor, they found that the 5-year patient survival was significantly better for lupus patients than for non-lupus patients, but the 5-year graft survival was significantly better for non-lupus patients. The risk of acute rejection was similar. Looking at the data for patients who received a kidney from a living donor, again, the 5-year patient survival was significantly better for lupus patients. There was no difference in 5-year graft survival between lupus and non-lupus, and the acute rejection was significantly more frequent for lupus patients. However, the limitations of the registry data, apart the huge difference in the number of patients between lupus and non-lupus, is that the control group is inadequate because there are different criteria for inclusion, different period of transplantation, different type of treatments. Moreover, we have little information about the type and the length of dialysis, the clinical conditions of the patients, the presence of antiphospholipid antibodies, adherence to prescription, and so on. Therefore, we decided to compare, in our experience, the results observed with 35 transplants in patients with systemic lupus, and in 70 controls. 35 of them were transplanted immediately before patients with lupus, and 35 immediately after patients with lupus. And as you can see, there was no difference not only in the main parameters, but also in the type of dialysis, in the HLA match, panel reactive antibodies, and so on. At 15 years, the mean follow-up was 90 months. There was no difference in patient survival rate between lupus patients and non-lupus patients. And the same was true for the renal graft survival. Looking at the results at the last follow-up visit, there was no difference in death, graft loss, functioning graft, mean serum creatinine, and mean proteinuria between the two groups. Recurrence of lupus nephritis may be an issue for transplant patients. However, in this review of the UNOS registry, Contreras and co-workers found that only 2.4% of transplant recipients with lupus had recurrence of lupus nephritis. Black race, female gender, and young age, lower than 33 years, were independent risk factors for recurrence. Graft failure occurred in 93% of patients with recurrence, 86% of those with rejection, and 90% of controls without rejection. But taking the cumulative results of this study, only 7% of graft failures were attributable to recurrence of lupus, compared with 43% of rejection. And these investigators concluded that although recurrence increases the risk for graft failure, it contributes far less than rejection to graft failure. Looking at a comparison between transplantation and dialysis, in this American study, it was shown that transplant patients had a better survival than patients who remained on dialysis. And the same was seen in this study made in Korea, better in patient survival with transplantation in comparison with either hemo or peritoneal dialysis. So we can say that the short and long-term patient and graft survival in kidney transplant recipients are similar for patients with lupus and sex and age-matched controls transplanted in the same period. The risk of recurrence is variable and can have an impact on the outcome of the single patients with recurrence, but it's not a major factor on the cumulative results of transplantation in lupus patients. There is no reason for excluding lupus patients from a program of transplant. However, it may be advisable to delay renal transplantation in those few patients who have a persistent aggressive lupus and in those with heavy side effects caused by previous vigorous and prolonged treatment. So in conclusion, Mr. Chairman and dear colleagues, in the majority of patients, biological and clinical lupus activity reduces while renal failure progresses. In these patients, steroids and immunosuppressive drugs